Good afternoon. Buenas tardes. Today is a very special day for us. The Congressional Hispanic Leadership Institute is presenting the last briefing of the 2018 year of our briefing series. My name is Juan Negron, and I am the Director of Programs and External Affairs for the Congressional Hispanic Institute, and today I'm honored to be participating and starting the panel with my boss, President and CEO Marianne Gomez-Horta, and our CHLI board and congressional member, Ileana Ross-Leighton. With that being said, today we have a really interesting topic, and it's called the value of medicine. And I'm gonna go a little bit side of script here because I'm an only child, son of a pediatrician, a godfather who's the Secretary of Health and Human Services of Puerto Rico, and a full family of doctors. And after the hurricane passed in Puerto Rico, the value of medicine has definitely been an important topic. So it's not only important right now here in the mainland, but also everywhere we go. I said, to set the tone, I found a quote by Hippocrates that says this: wherever the art of medicine is love, there is a love for humanity. So every single person here today has a love for humanity. We're giving this speech. I would like to start thanking Pfizer, Herbalife Nutrition, and AT&T for being sponsors of this amazing briefing. Without our staff, this wouldn't be possible, so I always call Michelle, Rudy, Alicia, and our global leaders, and definitely to Roy Cosme, who's been hand in hand with me to making this possible, Robert Popovian, and all of our panelists, who I think we've become friends for the past month, speaking almost every week. So without further ado, I'm going to introduce my boss, Marianne, who she will be introducing our amazing CHLI madrina, Congresswoman Ileana Ross-Leighton, who is saying goodbye, not to CHLI, but to Congress after many years where she has devoted her life. So Marianne.
Okay, buenas tardes, good afternoon. So the Congressional Hispanic Leadership Institute holds these briefings throughout the year, and many of you know we try to do one per quarter at least, depending on the topics that are being discussed here, so that we're timely and relevant throughout the year with our topics that impact the Hispanic community. These are always in-depth conversations, diverse points of view, which is one of kind of our trademarks in terms of the thought leadership, making sure that we always have different points of view from across the aisle, as well as from in some cases, from global issues. Today's discussion will be, as always, informative, conversation, an opportunity to ask questions, an opportunity to learn from each other and from the audience. I'm going to keep this short because the person that I'm going to introduce next is dear to all of us. We've already taken some pictures, I know, but we're going to take some more, I'm sure. For those of you who may not know, CHLI was established in 2003, in November of 2003, so technically this is our quinceañera month. Yes. Congresswoman Ileana Ross-Leighton and her staff were part of founding the organization, along with the Honorable Lincoln Diaz-Balart and Congressman Mario Diaz-Balart, all of their staff at the time, and a slew of other staffers and corporate executives who really thought it was important to have a centrist organization here in the organization that really, in Washington, that really spoke about different points of view and advancing the Hispanic community's diversity of thought. One of the things that comes up on a regular basis when I talk to people about CHLI is that we do our best every day to walk the talk of diversity and inclusion. If you look at our leadership on our board, we have members from both sides of the aisle, from members of Congress as well as corporate, and we have the depth and breadth of diversity as well on the board. Not everyone on the board is of Hispanic heritage, and that is done intentionally. We strongly believe that if we as a Hispanic community want to be invited to other conversations, want to be included in other people's events, want to be part of healthy discussions and debates on serious topics, then we need to have a diverse and inclusive board of directors as well. So we can start those conversations kind of entre la familia, right? And how you get cozy, then it's easier to talk to others. So please welcome to the podium our godmother, as we refer to her, Congresswoman Eliana Ross-Layton, who is wrapping up 30 years of public service. I'm sure we probably all have tips for her on how to re-enter into the private and sector. But she served in the 27th district in South Florida, but really was more than just a member to Florida. She was a member and a pioneer to many women, to many Latinos. And so please join me in a big applause for Congresswoman Eliana Ross-Layton. Yay.
Thank you. Thank you, Marianne. Thank you. Now, Marianne says that they have these briefings, what did you say, quarterly? Yes. I think she has them every day or every week. It seems like there's one on trade, and there's one on high tech, and now this one on they're just constant. And because CHLI is a very with it organization, always in tune with what is going on. And I've been so proud to have been associated with CHLI, as Marianne said, since its inception. And yes, I have been in Congress almost 30 years, and 7 years in the state legislature, so it's almost 40 years. I'm going to be in withdrawal, and I need to find a support group. But it has been the greatest honor of my professional life. CHLI is such an outstanding organization. I am thrilled that Marianne and our founder, Congressman Lincoln Diaz-Balart, have asked me to join their board. I don't know if I'm supposed to say that. I'm not leaving the board. Okay, I am on the board. There you go. That's why it seems like we're having briefings every week. So I'm going to be part of the advisory council, and so I will be leaving this wonderful institution that I love so dearly, but I will still be a part of all of these organizations, all of these meetings, and all of these briefings. But what a wonderful adventure this has been for me. I came to the United States from, what's her name? From Cuba when I was 8 years old. Ni sabía ni papa frita de inglés. And so here I am in the United States Congress, and it says a lot, not about me. It says a lot about the opportunities in this great land. And that's really what CHLI is all about, opportunities for all. And I'm just really pleased to see an outstanding group of speakers. Every CHLI event is really quite stimulating. So I'm just saying, see you later. I'm not saying goodbye. Así que es hasta luego. No es que me voy por una eternidad. I'll still be a part of you, and I hope that you will be a part of me as well. Muchísimas gracias, Marianne. Thank you to these dynamic speakers, and I look forward to reconnecting. And thank you for that lovely thank you card that you just gave to me. Thank you. Bueno, muchísimas gracias. Muy agradecida. And on with the show.
So thank you,
We
Congresswoman.
get
again.
kicked out of our office, maybe we have one more hour. So they say, thanks for your service, don't let the door hit you on your way out. So we beg to be there till Friday, so maybe we will. Okay. But you can run me in the halls.
So I'm gonna interrupt for a second because we took pictures earlier. So I'm serious. Anybody else want pictures with their queen madrina?
I'm ready. They're gonna have to have a cardboard cutout.
I'm sure the speakers will be okay. Come on, man.
Okay,
Everybody else
come on
go.
over.
Hey, Olivia.
Como estás, amigo?
Their month.
But we will be officeless in a matter of hours. So if you see me running around the hallway, looking like just, I will try to do that.
There you go.
Gracias. Come on over, because I need to be somewhere else. Come on over. I need to pack up. Thank you. Come on over. Thank you. You're so nice. Thank you. It's so good to be seen. Thank you. Come on over. These boots are made for what? I wish it were Sinatra. Okay, gracias.
Thank you. You did it your way.
Gracias. Venga acá. Gracias.
Everybody will send each other the pictures.
Thank you. Okay. Thank you. You are so nice to have you. Appreciate that. Okay, bye, guys.
Thank you, Congresswoman.
See you. You're so sweet. Thank you. Bye, everybody.
Now, I would like to officially introduce to you, as I was mentioning before, our panel for today, The Value of Medicine. And we have a really special moderator who's not only a CHLI alumna, but is also a legislative assistant here at the United States House of Representatives. And we're talking about Eliza Ramirez, who worked for Congressman Michael Capuano from Massachusetts. And Eliza works in a bunch of topics, from foreign policy to defense, veterans, telecommunications, trade issues, and health. Eliza has been an instrumental working with key international actors to securing funding for humanitarian and peacekeeping efforts in the Middle East and Sub-Saharan Africa. In 2016, she was named 40 under 40 Latinos in Foreign Policy by the Huffington Post. Ramirez started her Capitol Hill career on the Senate side, where she worked for Senator Barbara Boxer and Senator Bob Menendez. She holds a bachelor's degrees from California State University, Fullerton. So without further ado, I present to you Eliza Ramirez and our panelists.
All right, let's get started. Is this on? No. It's not on. Now it's on. Wonderful. All right, so I want to dive right into the questions, but I will introduce, of course, our wonderful dynamic panelists. So starting from my right, we have Dr. Daniel Hernandez from Global Healthy Living Foundation. And following that, Dr. Madeline Feldman from the Coalition of State Rheumatology Organization. Olivia Dickey, Health Legislative Assistant, works for Representative Buddy Carter. And I do have to say, Olivia, because I just found out, congratulations on getting into Harvard. She'll be going there soon. Oh, yes. And then from Olivia's right, we have Robert Popovian from Pfizer. And then last but certainly not least, we have Terry Wilcox from Patients Rising Now. So thank you all for being here. And my first question will be for Dr. Hernandez. So I do want to start off by saying that our current health system is not effective or beneficial to all economic and social classes. So if patients do not benefit from the prices negotiated on their behalf by the insurer or the pharmacy benefit managers, what can be done for this to be solved? Do patients benefit from negotiated prices for other services within the healthcare ecosystem?
It's many questions in one, and they gave me 5 minutes, so bear with me. I'm going to speak as fast as possible. I think the first thing that you said is very true. The lower and middle classes in the United States are negatively affected by our current healthcare system as how it is portrayed right now. Our Hispanic population, being that a large portion of it does fall under these two socioeconomic classes, they're affected by it even a little bit more than the normal population is because of this. Now, how can we fix it? I'm sure we can spend all day thinking of different ways to fix this, but to think about this in the most immediate future, I think we can do two things. We can do regulation and we can do accountability. So what I mean by regulation is we should start regulating pharmacy benefit managers a little bit more than what we've done so far. The ban on gag clauses that currently passed is a great first step, but I think a lot more has to be done, such as including Medicare and Medicaid in this ban, which currently it doesn't include. Another thing that we can do is give those states the autonomy and the power to regulate these PBMs as they see fit. a way that they can regulate it is by forcing these pharmacy benefit managers to have a fiduciary responsibility to their patients. And if they force them to do this, these pharmacy benefit managers are going to be forced to stop doing programs that are benefiting them positively in the bottom line, but they're completely affecting these patients in a very negative way. One of these programs is called the Copay Accumulator Adjuster Program. And what this program does is it basically ignores copay cards in the patient's deductible. Other programs such as this are also in effect, and if we do regulate these these PBMs, I'm sure we can create a big change that's necessary right now. The other thing is accountability. We should hold these PBMs accountable to reflect the prices of drugs to the patients when manufacturers decide to lower drug prices. This would benefit the Hispanic population immediately, as the recently lowered drugs are used to decrease the high cholesterol in patients. Since this is a huge disparity in the Hispanic population, this would immediately benefit the patients and our Hispanic population. Now, for the second question, if negotiated prices other than in drugs benefit the patients, I think currently they do. These negotiated prices to see a physician, these in-network lists, do actually benefit the patient because they do pay less, and it is a negotiated price between the insurance company, the physician or the hospital, and this patient is able to pay less. Now, with drugs, it's very different because the PBMs are the ones getting the discount, and it's not being reflected into the patients. I think that was 5 minutes.
You have a few more if you want to add. But that was a very thorough answer.
I think I'm good.
Wonderful. Thank you, doctor. For the next doctor, Dr. Feldman, since you mentioned the gag clause, but Dr. Feldman, if you could explain to the audience what this pharmacist gag clause is, because in the medical world, there's a lot of acronyms, or you throw a lot of complex words, so that's why I'm asking if you can just explain to some of us what the pharmacist gag clause is. And does the law go far enough to protect patients from overpaying for their medicines? And what can we learn from various state laws that have recently passed it?
Well, we'll start with something simple like the gag clauses. I am a rheumatologist in private practice, so my patients have autoimmune diseases like lupus, scleroderma, rheumatoid arthritis, and consequently they pay a lot for their medications. When a patient goes to the pharmacy and they have insurance, and usually it's for the lower priced drugs, perhaps a prescription of escitalopram, which is an antidepressant, and the copay is $30. But if they bought a month's supply without using their insurance, it might only be $12. But the pharmacist, because of a contract with the pharmacy benefit manager, of which the top three in the United States are Express Scripts, CVS Caremark, and Optum Rx, in their contract, it says oftentimes that they can't tell the patient that it's cheaper to buy the drug not using their insurance. And so that's been known as a gag clause. And it's, it just seems, I don't even want to use the word un-American, but completely unethical to have a way that the patient can pay a lower price and not even be able to tell them. So yes, that was passed. It was bipartisan. This would be kind of hard to disagree with it. But I think to sort of build on what Dr. Hernandez was talking about, we're talking about access to medicines, access to medical care, and that really means availability and affordability. And if either one of those are disruptive, the path to access is disrupted. So when we look at, particularly if we're talking about drug pricing, So we need the availability. So we need the manufacturers to make the drugs, and we need them to make enough of the drugs. And then they have to be affordable. Well, for the most part, I will tell you, the specialty drugs that are very expensive, the ones you see advertised on television, if they're not covered on the insurance, I don't have any patients that could afford them. So what has happened is, as we all know, the insurance companies set up formularies. And formularies are the drugs, essentially, that they'll pay for. And they have to choose which drugs are on the formulary based on something. And there is a preferred list. If you've ever been treated for hypertension, diabetes, high blood pressure, you know, your doctor is forced to use the preferred list first. And if you fail those, then they can move on to a different drug. So how do they pick the preferred list? And I think this all goes back to value, because we want to pick drugs that are efficacious, are safe, and affordable. So you would think those would be the three things that would be used to decide what's on the preferred list. Well, it's not. It goes back to what Dr. Hernandez said. And we all hear the word rebate, rebate, rebate. You know, I remember I first heard it with Best Buy. You'd go to buy like a tape player, and you'd get, if you sent in your receipt, you'd get a $10 rebate. Well, that's sort of how it is for the formularies. Every time a prescription is filled for a particular drug, the manufacturer then pays the pharmacy benefit manager a certain percentage of what it cost. So how the drug gets onto the preferred list is not the lowest price drug. It's actually the one that pays back to the PBM the most money. So think about that. The list price, which is a very high price, times a percent discount, I will give you 50% back on this drug every time a script is written. And then the market share, which is how many scripts are written. So those are the three variables: the list price, the discount, and the market share. If any one of those three goes up, regardless of how efficacious your drug is, you have a much better chance of being on the preferred list. So we talk about competition, and we need to bring more drugs to market, because the more drugs you have, obviously the price will come down. Well, there's two ways competition works. One, it can lower the price. If you're building a house, all things being equal, the more contractors bidding, everybody tries to underbid the next one, so you get the lowest price. And you're going to choose the one with the lowest price if the quality is the same. In our drug supply chain, it works just the opposite. The more manufacturers bidding, it's as if, you know, if you're going to buy a house and then there's that favorite house on the block that everybody wants, the more people bidding, the more competition, the higher the price goes. And that's how it is to get onto the formulary. So we have to think about these terms like we need more competition. More competition oftentimes will raise the price. It's not the lowest priced drugs. It's the one with the lowest cost for the pharmacy benefit manager. Now, I'm not here to blame the pharmacy benefit managers for everything, because there are manufacturers, and they're the ones that set the price. Is there an incentive to raise the price to get on the formulary? Yes. So it is a very complex, I've taken a very complex issue and tried to make it as simple as possible. So unfortunately, there's not going to be any simple solutions. It's going to take compromise on both sides. But I would submit having a formulary, and there's nowhere else in the world that does this. We talk about the drug prices in Europe, and why can't we have those prices here? Because they don't have a formulary based on the highest price concession. They have a formulary based on the lowest price bid. So when a manufacturer over there gives 80% off, it's 80% off the price, and that's what the government pays for it. Here, 80% off goes to the middleman. So it's going to be very difficult to bring down the price of drugs until we fix the way it's managed. And that gets to other legislation. So we have the gag clauses, which regulate the PBMs, and then then we've got the whole ERISA problem. You know, if it's an employer-based insurance, then it has to be federally regulated. If it's not, then the states can pass legislation. And I'm happy to say I'm from New Orleans, Louisiana, and we just passed some nice regulation for pharmacy benefit managers. They have to at least tell the insurance commissioner how much their rebates are, because there's no way to get at the problem until we have some transparency. So transparency, state legislation, and federal regulation, I think, are going to be needed in order to fix the drug supply channel. I don't know if that was the question that you asked me, but I have a way of digressing.
That was perfect. Next question will go to Robert. And so it's great that we're talking about cost. Let's talk about reform. How could reforming current policy to move away from the current contracting structure, rebates, fees, and spread pricing help patients' affordability and maintain biopharmaceutical innovation that they so desperately rely on?
So that's a great question. I want to go back to what is mine on now? Yes. I want to go back to what Daniel said. So what happens in the world of pharmaceuticals is absolutely different than what happens in every other sector of healthcare system. So currently, if I walk into my dentist's office and I have a coinsurance or a deductible, the amount of money that I pay based on the coinsurance or the deductible is based upon a negotiated price that's been done on my behalf. That doesn't happen in pharmaceuticals. So what we need to do first and foremost is to make sure those negotiated prices are passed on directly to the patient at the point of sale with pharmaceuticals, as we do with every other segment of healthcare. So if I go see somebody who's a physician, when I walk out of their office, if I have a coinsurance or a deductible, it's based on a negotiated fee that's been done with that physician or that hospital. So somehow or another, the pharmacy benefit managers and the insurers have convinced the world that this could not be done in the pharmaceutical segment. Well, it can be done in every other segment of the healthcare system. So that's one we will do to be able to immediately lower the out-of-pocket cost for the patients. The other thing is, and it delves into the issue of spread pricing a little bit, as well as the gag clause. Because the gag clause was a nice legislation that passed, and I know Representative Buddy Carter was the one that actually spearheaded it in the House of Representatives. It was a great piece of legislation that passed, and it was necessary because it was actually taking place and not allowing pharmacists to disclose to the patient when they show up at their pharmacy that they actually get their medicine cheaper. But it could go further. And the way it could go further is to prohibit clawback or spread pricing. So what is spread pricing or clawback? Spread pricing is when a pharmacy benefit manager charges $10 from the state Medicaid program while they reimburse the pharmacy $5. So they take the spread and that becomes their profit. So people say, oh, come on, that's not a big deal. Well, state of Ohio, last year they figured out that in the state of Ohio, the state Medicaid program in Ohio, overpaid by $250 million, billion, not million, $1 billion in this spread pricing scheme. And because of that, they basically fired all of their PBMs that were managing all of their Medicaid contracts. This is not just in Ohio. This is happening in Texas, it's happening in New York, it's happening in Pennsylvania and several other states. So that's another thing. We need to stop the spread pricing because that affects what the patient pays, right, at the counter. And the third thing is the clawback issue, which is my fear is that if we don't address the clawback, the patient walks in, and this has happened to me personally. So I walked into recently to a pharmacy, and it was an antibiotic for a generic for my daughter. And they didn't have my pharmacy benefit manager's information in their system. So when I went to the counter, they said, well, this is a cash payment for this pharmacy. And I knew my co-payment for a generic is $35 based on the Pfizer plan. When I went to the counter, they said the cash price is $18. So I'm like, save $17 right there. So I said, oh, hold on. Put my information in the system just to see, because Pfizer has a provision in their plan that mandates that I pay what the pharmacist gets reimbursed, not necessarily anything else. So when they put the information into the system, I walked out paying 84 cents. So it went from 35 to 18 to 84 cents. And that's what needs to happen with the clawback. That needs to be eliminated. Patients should pay what the pharmacist is being reimbursed. Not, because my fear is if they don't, Patient walks in and they pay the cash $17 or $18 that I was going to pay. I was going to ask the pharmacist for that to be applied towards my deductible. So it had to be processed through the insurance company or the PBM. And at that point, the PBM wasn't going to leave the pharmacist keep that money. They were going to come and claw back the difference between the 84 cents and the $18 that I paid. So that needs to be eliminated, and a lot of states are doing that, including Louisiana has passed the law, and Ohio has done it too, and several other states, California is one. So those are the things that immediately can help patients with out-of-pocket costs. So when, just putting it in context with clawback, right? So people said, so what, it's generics, you know, why do you care as a pharmaceutical industry, or why do you care about price, spread pricing because it's mostly in generics? The reason we care is because every dollar spent additionally, 100% of the blame comes back to the pharmaceutical industry. So we need to make sure, as Dr. Feldman said, get rid of all this nonsense that goes on into the pricing, then we can have an honest discussion about drug pricing. Until then, you can't, because it's all over the map. So just to put it in context on the clawback issue, in just 1 year, one health insurer or one PBM, 1 out of 4 prescriptions were clawed back in a pharmacy, which included mostly 28% of the generic drugs that were dispensed in that pharmacy, in addition to about 8% of the brand name drugs, to a tune of $130 million. So in just that 1 year period, in that one PBM, patients overpaid by $130 million. This is actual payment that was out of their pockets. I believe those are the things that we can do immediately to help the patients out.
Robert said something that reminded me, believe it or not, that I forgot to say. In putting the formulary together, so one of the drugs that my patients use, the list price is $6,000 a month. And depending on the contracts, the pharmacy benefit manager may get it as little as $2,000, $2,500. But my patient's co-insurance, the 20%, is based on the $6,000. And that's what happens with diabetics. The PBM might get it for pennies on the dollar, but the diabetic has to pay their co-insurance based on the list price that no one has ever paid.
Yep.
So there's a really quick way to get the patient to pay less, would be to get the, after all price concessions, not just the rebates,
That's right.
but the fees as well. Subtract all of that from the list price of the drug and let the patient then pay their co-insurance on that price, not a fake price. Sorry.
Robert, were you done with your point?
No, I think that, no, don't worry about it. And that, we can get into a further discussion that it's not just about rebates. That's another thing. The rebates has become the shiny object that everybody talks about. Frankly, fees have taken over rebates as the percentage of how much we give back. Just to give you guys an idea, pharmaceutical industry as a whole, in 2012, gave $74 billion back to the system in form of rebates, fees, concessions, all these things. In 2017, that number was $153 billion. So in other words, we had a 100% increase from $74 billion to $153 billion. Drug spending during the same period of time, 1212 to 1217, went up only 48%. So 100% increase in concessions given back, drug spending increased only 48%. Same period. So when people say, well, this affects premiums, because that's their favorite thing to say, premiums went up by 100% too. So the concessions, we can give concessions back as much as we want. The premiums are not being affected by these concessions. It's just a red herring. Thank you.
Thank you. And so Olivia, I would like to ask you the next question. And Robert alluded to this with the out-of-pocket costs, but if you can add more to that on what we can be doing to lower out-of-pocket costs for patients while reducing healthcare spending overall, and then please add in with your boss what he spearheaded, of course, on the healthcare front.
Sure. So my boss, Congressman Carter, is the only pharmacist in Congress. So, you know, bringing transparency to the PBM industry is his #1 goal. He has seen it firsthand. I don't know if you all were watching a recent Energy and Commerce hearing where Debbie Dingell was speaking, and she said, you know, I went to a pharmacy, They told me my drug was $1,300. She said, well, okay, I know Buddy Carter, though, and he would want me to ask how much it actually costs. So she asked the cash price of this drug, $1,300. They told her the cash price was $40. So thank goodness my boss, just instills this in every single member. But she saved so much money on this drug because she knew enough to ask. And so that's why the gag clause legislation was such an important first step. Like Robert said, my boss spearheaded that effort in the House with huge bipartisan co-sponsorship, and we had the same bill as was over in the Senate with one minor tweak to it. So Congressman Carter is really pushing for any sort of transparency in the healthcare system, and that's certainly warranted. But I think one thing, we've certainly been paying a ton of attention to PBMs, and they are certainly a huge driver of healthcare costs. But I think one other area that people are neglecting is where hospitals play into this. So, for example, we had a patient write into Congressman Carter saying, I was receiving an infusion treatment with my doctor, and I just got a new bill, and it went up astronomically. So we looked into it. Turns out that physician group had been bought by a hospital. So that switched the infusion drug from Medicare Part B into Medicare Part A. And nothing changed for that patient. Still getting the same drug, same doctor, same parking ticket, all of that. But the only thing that's changed here is the price went up just because it got switched into the hospital setting. So I think that's one thing we really need to look at. We've been talking a lot about PBMs. Just to put it in perspective, the 3 largest PBMs currently control 78% of the population. So this is not just, a couple health plans that are dealing with them. This is 78% of the population. We've seen drug costs from 1987 to 2008. Drug costs have increased by 1,010%. And out-of-pocket costs for patients have increased by 169%. Over that same time period. So, when PBMs come in and say, we bring value to the table, we're lowering premiums, we're lowering out-of-pocket costs. Those numbers just clearly do not line up. So there's a lot of misinformation, so we certainly need more transparency there. There are a couple efforts to go after DIR fees, bring it to the point of sale. I know we're waiting on a rule that might come out this week from OMB that could put it to the point of sale, fingers crossed. And I think another area that we need to look at is how the plans are benefiting from this. We've seen patients who are paying a certain amount out of pocket, but it turns out that their plan sponsor is actually making more than that patient is spending on it because they're getting the drug at a discount and the patient is not paying at that same discount due to rebates. So that's another area we need to look at. And I think finally, this is something that's not only in the drug space, but health literacy as a whole in this country is incredibly poor. People don't understand what the difference between a deductible, out-of-pocket costs, coinsurance, these are terms that are frankly foreign to people. To think that a member of Congress only knew to ask how much a price of a drug was because my boss is very chatty, that just shouldn't be happening. She's a very smart woman. So I think health literacy, and especially when it comes to the Hispanic community, there are barriers to access. Just making sure that the doctors even speaking the same language that they can go in and understand. So I think that's how we can ensure there is value while keeping down the cost of healthcare.
Thank you, Olivia. Terry. So it said that some treatments like cancers, when administered in a hospital outpatient setting instead of in a physician office, costs 100% more. So why is this? And does the patient have the option in deciding where to have their treatments?
Well, there's a variety of reasons why it costs 100% more, and I'm going to start with the story of where it costs 500% more.
Okay.
We have a patient. I am the executive director of an organization called Patients Rising Now, and we work with patients and speak to patients daily on their access to care issues around the country. And oftentimes, and we help patients with everything from the cost of the access to their medicine to, finding the right, finding a second opinion, even going so far as to help them figure out their medical bills. I actually had a woman send me all of her medical bills one time so that I could help her get her LabCorp stuff in order. It was not my wheelhouse. I had to kind of pass that off. But we get all kinds of things. And one of the things that we got one time was a bill, and it was a drug that I know the list price to be around $5,000 in the hospitals. I mean, in any setting, that's the list price. So I know, you know, and I don't know for certain if this hospital was a 340B hospital or any of these other things, which I can talk about in a minute, but the price on the patient's bill was $27,000. Okay, it was $27,000. And then the next month, they thought, oh, we got away with the $27,000, let's charge her $37,000. Like, you know, so, and this is for not even an actual chemotherapy drug. This was for a supportive care drug, which is like, you know, something to sort of help with your nausea or whatever after. So it's insane what goes on. And oftentimes, you know, the hospital setting, my father used to run hospitals, and he always used to tell me it's insane what we would try to get away with. But he went from managing hospitals when I was a much younger child to when he retired, he was running a cancer clinic in the community setting. So he went full spectrum to where I'm about to talk about, which is where most patients do want to get treated, which is as close as they can to their home. The hospital setting charges more because they can, they have, and granted, it does cost a lot of money for, you know, all those, you know, the buildings and the people and the staff and the nurses. We do not deny that at all. It is definitely more expensive. But they also have, in many ways, I say, more benefit than some of the community setting doctors, because you can see, I don't know how many of you know what the 340B program is for hospitals, but it's where they're allowed to purchase drugs at a much cheaper price, and then to be able to help the neediest patients, right? So they can get them at a much lower cost and help those patients. But they oftentimes do that across the board because there's no transparency or accountability for them to say if those drugs are treating, who those drugs are treating. So they can actually get the drugs at super low prices and then in turn go and sell them, you know, back to Medicare, or charge, you know, the average sales price or a regular insurance plan, whatever price, and get this huge markup on them. So they're able to do a lot more than the community. They're able to take advantage of this program, whereas if you go to doctors in the community setting, which is where most patients would like to be treated, and would prefer to be treated closer to home. There's actually been studies done that say patients do better closer to home than having to travel far away. Some of the largest barriers to access for patients, especially in the cancer treatment setting, are transportation and caregiving, whether it's child care or parent care or whatever. So oftentimes, especially when a patient is in a lower socioeconomic, you know, they have barriers from income barriers to treatment. They just are oftentimes treated wherever they can get treated. Okay, I guess that's, you know, nobody's sending them shiny little brochures or talking to them about how they can get second opinions nearby or all the clinical trials that are available to them. They don't get that kind of consultation. They're just lucky. I mean, and I speak from having an aunt in Texas who was treated this way. I mean, she just was lucky to get treatment. I mean, she was in the state Medicaid program of Texas, and she just got treatment. And so oftentimes they don't get that. And how can we make that better? Well, there's a variety of ways that and in my opinion, that we can make that better. And one of them is looking at is figuring out ways to bring patients. The fact is, in the community setting, closer to home, there are other avenues to explore besides just the hospital setting for patients to be treated. And it's developing some of these programs. And one of the things, we just started a Facebook Live at Patients Rising Now, because one of the things that we're trying to do is talk directly to the patients, speaking to your point about health literacy. You know, we even find that very educated people don't know all of these terms. And when you start talking about people with language barriers, cultural barriers, and socioeconomic barriers of all sorts, it becomes astronomically more complicated. And they lose trust in the system. They don't adhere to treatment if they can't, if they don't understand it or they can't meet the demands of following it. I mean, cancer treatment especially involves many, many appointments, and there's so many barriers that patients face in that way. And it's figuring out how we as a society can, and we've been looking a lot lately at Patients Rising, how we as a society can figure out how to, I know we, in Congress and here in Washington, D.C., we all look at healthcare as something that's national because we're here in the national center of things. But healthcare is actually local. It's really local. It's in your community. It's where people live. And it's being able to figure out how to bring those dollars and those ways to be able to support patients in that manner in a cost-effective way. And you look at all kinds of examples of ways small, local, regional groups of people are making a huge difference in healthcare delivery. Case in point, if you look at, I just read the other day, the city of Fort Worth, it's a really small population of people, but all the state employees for the city of Fort Worth, they were able to save almost $5.8 million last year just by implementing all these new kinds of options for patients. And in my mind, it's like, how can we take that in our state Medicaid programs, and how can we do these things for patients locally and regionally to allow them to be able to benefit from some of these things that, someone with great insurance or, high level of understanding the healthcare system can do. So I don't know, I probably talked too long. I can go on forever, so I apologize.
No, I can
probably
listen to
got
this
way
forever.
off. But
Thank you, Terry. I do want to end with my questions because I want to make sure that at least we can get one, maybe two questions from the audience. But my last question will be, and this is for anyone on the panel, but let's talk about innovative medicine because that's where we're headed. And if you could talk to us about upcoming innovative medicine that we could be seeing very soon or in the near future, and what reimbursement models can or cannot work to help pay for these therapies.
So maybe as the industry person, I should be talking about where we're going with. So you're going to hear words like precision medicine, words like gene therapy, that are going to come. You're going to hear these things in a variety of disease areas. It's not just going to be one disease. It's not just going to be cancers. We're seeing gene therapy work and, hemophilia and everything else. There are tremendous innovations that are taking place in medicine because we know more about the disease than ever before. In fact, I was talking to someone yesterday about mental health, and the dam's going to break in mental health as soon as we learn more about the disease. We just don't know enough about it. But so what do we do with these? Because clearly they're going to be out there. Incrementally, they're going to be extremely expensive for individual patients. There's going to be small numbers that are going to be affected by them. Just to give you an idea, and these are mostly considered rare diseases. So in the United States, there's about 25 million Americans who suffer from rare disease. There are about 7,000 different rare diseases in the United States. So it's really dispersed. It's a very small number of patients and innovation that needs to be garnered for each one. When we have cholesterol is a big issue in the United States. Hypercholesterolemia affects 80 million Americans. So just that one disease affects 80 million versus 7,000 diseases affects 25 million. So we're going to have a lot of innovation. Incremental cost is going to be tremendously high. The reason being is that Pfizer's doing research and development and innovation to put it back into the system, and all the failures are not going away. We're not changing the model. It's coming. Dr. Gottlieb is doing a better job at the FDA trying to change it, but it's coming, but it's not here yet. So how do we pay for it? I think we need to rely on new payment models. Frankly, pharma companies need to put their money where their mouth is. If it doesn't work, you don't pay for it. If it works, great, you pay for it. But we need to do a different way of doing business than business as usual of rebating, contracting, and all these other nonsense that goes on, because this new class of medicines are not going to be conducive. Nobody's going to be able to afford it. When you come out with a gene therapy that is about $1 million, $2 million, there's only like 0.00001% of the U.S. population that can afford that stuff. So.
The other thing is, and I know we've come down hard on PBMs, but we really can't let the pharmaceutical manufacturers off the hook in this either, because it takes two to tango. And we wouldn't have the situation that we're in if the pharmaceutical manufacturers would agree to make less of a profit as well. We're trying to cut out the middleman, but they need to do it as well. So this is not just a one-sided thing. There's a condition called spinal muscle atrophy, and it affects just hundreds of patients, maybe thousands, but children usually die before the age of 2. And there's a gene therapy that's come out, and it looks as though the manufacturer who will make it says the cost of the therapy is $4 million. So we're going to have to make some decisions as a country. Hepatitis C cure is a great example. It's definitely worth $80,000 to cure hepatitis C and forego hepatomas, liver cancer, liver transplants. The thing that's going to break the bank in the United States is going to be Alzheimer's and Parkinson's. It's going to be the neurodegenerative diseases. So we're depending on pharma to come up with the cure, but we're also depending on them to price it in such a way that we'll be able to treat the millions and millions of Americans that are going to succumb. So we've got these great gene therapies. We've got biosimilars, which are the quote-unquote generic. You can't make a generic of a biologic, but coming out. And if we can change the way the formularies are set up, perhaps biosimilars will bring the cost down of these very expensive drugs. But we need research money, NIH, going towards Alzheimer's, because that's going to break the bank.
And I think one thing we do need to be mindful of is the most recent Part B proposal by the administration that would set an international pricing index, which would seriously restrict any sort of research and development that could take place. You know, if we're doing a demo with 50% of the population on Medicare, that's one thing. But if we're looking at countries where people are at best on a waiting list for some of these innovative therapies that we're taking advantage of in the United States, you know, that is serious consideration. We saw back with radiopharmaceuticals that there just wasn't the reimbursement necessary to keep those up from CMS. I am concerned that for something so exciting like CAR T therapy, that if we don't have that reimbursement, we're not going to see any more development in that space.
All right, we have time for maybe 2, 3 questions. All right, I'm excited. Okay, so first question.
Hello.
All right, there we go. If you could introduce yourself, please.
Manuel Rosales with the Latino Coalition, and this is something just came to my mind is my premium went up $1,000 a month, and I'm just wondering what's the percentage of that is the drugs? What's the percentage of that that's basically to the physicians, or what's the percentage of that to maybe lab tests and other things? Because I'm just wondering if the drugs has a big effect on the increase in premium.
I can answer for physicians because I have contracts with every insurance company, and I'm not allowed to tell you how much I'm paid, but I can tell you every year it stays the same. My reimbursement has not gone up. Maybe I'm just a very poor negotiator. So the drugs are probably a big cost because as we have the innovation, it's going to be there. You know, my patients are maybe 3% of the population, but are 20% of the drug spend. And these are great drugs, but we need the manufacturers and the supply chain to figure it out so it doesn't cost as much.
So I think there's studies out there that show, like, if you take $1 from your premium, how much of it is sliced up into pharmaceuticals, hospitals, physicians, ancillary services, labs, things like that. So pharmaceuticals is about 10%. If you take $1 of the premium, 10% goes to drugs. The rest is basically, then the next, hospitals is the biggest chunk. It's about 40 or 50% of it that goes into the hospital system. And the best way to look at it is that when I testified in the hearing, the complaint was, well, we give up the, these rebates from pharmaceutical companies, it's going to increase the premiums. And the question was, how much does the premium increase based on drug spend? And generally, the drug spend is about 1% increase in the premium. So if you're getting a double-digit premium increase, that's about right. About 10% of it is total, 1% goes drugs, the rest is basically dispersed among the other services. But not necessarily, see, this is the thing. Just because the premium goes back doesn't mean that physicians getting paid more or pharma companies getting paid for more. There's more and more examples of drugs where we are taking price increases, double-digit, and the net price increase is in the negative numbers. And I always tell my supervisors and my business people that this is how you go bankrupt, because you keep increasing your price and you're getting a net negative return on investment. That's why the model needs to change.
Comparative shopping. There's an MRI of the knee in New Orleans can cost anywhere from $500 to $6,000 depending on where you get it.
Yeah.
So shop around.
Yep.
Anyone else? All right.
Hey, good evening. My name is Natasha. I'm from Puerto Rico. Nice to meet you and glad to be here with you guys. So you mentioned that, we talk about people that look for medical help whenever they can, that it's like lucky to get medical help. Many reasons can include because they can't afford it. They have language barriers. They don't understand it. They don't have any education. But what about immigrants, people? Probably they're using that money to pay for the legal process. They get sick because they overwork from 12 to 14 hours a day, 7 days a week. So, having an immigrant husband, I can say that is really hard for them. And they prefer to use that money to pay for the legal process rather than to seek for medical help. And also they fear go to a hospital because they think that they're going to face any legal consequence. So how can we help that type of community? Because especially in DC, we have a lot of Hispanic and immigrant people in here, and I don't think that it's fair for them to not receive medical help because they fear.
Well, that's why patient advocates were born. There are a lot of various roads to, different, there even Hispanic or cultural community organizations that help specific communities. Now, the issue with that is in this instance that you're talking about, there's probably not enough of them to go around to help support where you can get the free clinics and the free care and the support in that way. And part of that is probably it's another thing that's very similar even to those who do qualify for Medicaid. I can speak to people I know in my own family in Texas who have literally they can have Medicaid, they can sign up, and they just don't, right? Or they don't do that. Now, in this instance, somebody who wants to can't. It's being able to search, but also the language barriers of being able to search for that care. And I think that's just another thing of where healthcare, again, I hate to harp on this, but it really does become a very regional, community-based issue. And it's really about finding people within your own community that can act as your advocate, that can act as the advocate to help find those resources, to help do those things. Now, how we as a country do that, that's a very large question, probably for Congress. Or, but as far as a country decision, but I'm just talking about how they find support, within the communities that they live.
The DPC, or Direct Primary Care Movement, is trying to work in that regard, actually charging patients less than what they would pay if they use their insurance, getting plans where they can get all of the lab done for $10 as opposed to what a copay might cost them for that. So that is a movement that I think probably could be harnessed in areas where there are immigrants that either don't have insurance because they're afraid to sign up or don't have the money to sign up, they don't want the government, whatever reasons. But to have, I know Tulane University in New Orleans has been working and they've got clinics like that, not enough. But we could do more with that.
Definitely. You can also often find places that have a sliding scale similar to that. You can, the patients can pay nothing or pay whatever they can afford, kinds of things.
All right, and last question. Okay. With no more questions, if all of you could join me in giving our wonderful panelists a round of applause.
On behalf of the Congressional Hispanic Leadership Institute, our president, Marianne Gomez-Horta, and our entire team, panelists, and Elisa, thank you so much for the time that you've taken not only to fly or metro into Washington, but to spend time with us. And I invite you all to please stay. We have an amazing reception prepared for all of you with a couple of drinks and some divorce for you to enjoy. So once again, thank you.